Like these patients. Hello students, a very warm welcome to all of you to ENT Thursdays. Am I audible? Can you hear me? Can you see me? Can you hear me? So, we, okay, so you can hear me. Yeah? Yeah, I guess there is some lag. I hope all of you are enjoying studying whatever you are studying, whichever subject you are studying, and that is the way to learn anything. You have to enjoy whatever you are learning. Whatever you are learning, you should feel that you are learning something new, and this is going to stay with you for life. So, whatever we are doing in ENT Thursdays, we have done all the topics very beautifully in our marrow videos. What we are doing here is how we apply it when we go to clinics, because that is what is expected whenever a case is given either in exam or in profs. We are given a case, and when in exams also, MCQs also, when the case is given, if you are used to doing seeing patients in that way, it becomes very easy for you to immediately note down what the important things are. So these questions what we are doing, you have to apply it. You have to apply it whenever you go to the clinics. And the only way to learn is that whenever you are reading anything, like what we have done in the oropharynx also, whatever we have done in the neck spaces also, if there is anything that you what I'm saying and you have heard it, yes, but you do not know it, then don't just sit quietly. Go back and see what it is. The more for as something as simple as, suppose if I say that ophthalmic artery. Okay, so whenever we say ophthalmic artery, each and everything about ophthalmic artery should be clear to you, that okay, this is part of the internal carotid. From where does internal carotid give it? How does it come? You have Google with you, you have all the books with you, everything is there with you. So immediately in a second, the more you will get back to that, the more permanent your memory will become. So each and every time if you have any doubt in anything, go back and see it again, especially the pre-final, the final years. They have time now, so all of you can just go back and don't just try to settle down at anything that okay, this must be something. The more you are going back and seeing, this is just a small effort that you are taking right now, but in the long run it will be a lot of benefit to you. So, we will start with sinusitis, and this is one topic which, though appears very simple, but I see that so many of you send me messages regarding my friend, my parents, myself having this. What should I take? Okay, so this is something very practical. So, we are going to start with the first case. So, the first case we have here is, yes, you can start reading it. I will just, yes, the highlighter or the pen, I will just take that. Yes. Okay, so here it is a 37-year-old woman. She is evaluated for 2 week history of nasal congestion. So there is nasal congestion. She initially believed she had cold and felt better after taking over-the-counter combination of oral pseudoephedrine and diphenhydramine. Okay, however, her symptoms returned and she began having fever and increased nasal secretions. She has no drug allergies. On physical examination, the temperature is 101. There is pain on the cheek. So there is pain on the cheek. So whatever symptoms are there, we are marking that. Over the right maxillary sinus, anterior rhinoscopy shows erythematous turbinates. yellowish nasal secretions, and post-nasal drip in the pharynx. So this is something that you find so commonly in the clinics. Patients come with a complaint, नाक बंद था, सर्दी जुकाम था, ऐसा लगा कि हल्का फुल्का है, ठीक हो जाएगा, तो हमने केमिस्ट से ही दवाई खा ली, एंड द केमिस्ट, they sell more medicines than what doctors give. Yes, so she has taken oral pseudoephedrine and diphenhydramine. And what has made her come to you now? Because now she is having fever, the secretions have increased, and she is, yes, now feeling unwell. So you immediately do the anterior rhinoscopy, and this is the finding. So what do you think is your diagnosis? Okay, so all of you are telling me it is maxillary sinusitis. Okay, because maxillary sinusitis, because yes, because there is tenderness over the cheek. Okay, so wonderful. You told me it is sinusitis. Is it acute or a chronic sinusitis? Is it acute or chronic? Is it acute or chronic? What in the history is telling us here? So this is exactly how we approach any patient when the patient comes to us in the clinic. When the patient has come, these are the complaints that the patient has, and the first thing that we are going to see is this an acute presentation or is this a chronic presentation? What is this? What is the difference between acute and chronic? Yes, it is the duration. So tell me what it is, whether it is acute or whether it is chronic. Acute or chronic? What is this? Yes, all of you are telling me acute. Wonderful. What is the difference between acute and chronic? Acute is for less than 12 weeks and chronic is for more than 12 weeks. And that is going to change our management. That is why it is important to know whether it is acute or chronic. Okay, so wonderful. It is acute. So this is acute presentation that the patient is having. And we have confirmed that this is a maxillary sinusitis. Now, the next thing what we will like to do is we will like to manage this patient. Yes. So what is telling us that this is sinusitis? So what is the criteria for diagnosing any patient as sinusitis? And this is very important, and whenever you also have or your relatives have, friends have, you need to know. So yes, what is the criteria? When do we say that patient has sinusitis? What is the important thing that you noted here? What is the criteria? Yes, the patient has nasal obstruction. So one is nasal obstruction, second is nasal discharge. If the patient just has nasal obstruction or nasal discharge, you just see here, I've made this table for you. Nasal obstruction and nasal discharge, if these two present, nasal obstruction present, nasal discharge present, if both are present, we can say straight away this is rhinosinusitis. This is a definition of sinusitis. By chance, if the patient has only nasal obstruction, nasal discharge is not there. Okay, patient only says naak band hai ji, naak se koi balgam to nahi nikal rahi hai, only naak band hai. Then we need to have some additional features. So these are the additional features. Yes, there has to be either along with either one of these, there has to be facial pain, there has to be hyposmia, endoscopy if it shows mucopollulant discharge, or CT shows mucosal changes. Endoscopy shows mucopollulant discharge, polyps, or edema in the middle meatus. So any one of these, this one, either the nasal obstruction or nasal discharge, if both are present, we straight away say it is sinusitis. Or if either nasal obstruction or nasal discharge, along with that, any of these should be present, pain or sense of smell. And what we are seeing in this question, nasal obstruction is also present, nasal secretions are also present, and there is along with that there is pain also. Yes, there is pain, there is discharge. Yes, so now we know that this is sinusitis. Now the next thing is, should we give antibiotic to this patient? Which means, how are we going to manage this patient? Will we give antibiotic to this patient? What is the most appropriate management for this disorder? Will you give antibiotic? Will you just give supportive management, or will you like to do a X-ray of the paranasal sinuses or a CT of the paranasal sinuses, or will you directly post the patient for surgery for FIS? So if you are giving antibiotic, you have to be sure whether it is bacterial or not. If you're just giving supportive management, it means that you're sure that this is a viral etiology that you're dealing with. And what do you think? Will you give anti-allergics or antibiotics? Will you give antibiotics? The sinusitis is most commonly Viral. Most commonly it is viral, but here this picture, is this viral or is this bacterial? So this is again very important thing that you keep asking me. You send me the presentation and you tell me, this is my relative, my friend or myself, should I take antibiotic or not? If I should take antibiotic, which antibiotic should I take? So I feel that this is something that each one of you should be able to differentiate, and each one of you should be able to diagnose and treat. Yes. So tell me, in this patient, what do you think that this is a viral or a bacterial presentation? That is the next thing that should come. Yes, bacterial or viral. So what are the criteria which will help us to know that this is pointing towards bacterial? Yes. Very good. Yes, Waldemar says that this is yellowish nasal secretions. Very good. So, one, there are the nasal secretions. Yes, first was nasal obstruction, nasal discharge. So, nasal secretions, if they are mucopurulent, if they are unilateral. Now, always remember, always, whenever you will practice also, always remember one thing, whether it is for pharynx, whether it is for sinuses, whether it is for anything. If it is bacterial, usually the presentation is localized, whereas viral is generalized. Generalized means the patient will have sneezing, will have itching in the eyes, the patient will have lacrimation, patient will have cough. So when there are many systems involved, the patient can have GI diarrhea. So when the patient has multi-system involved, it is usually viral in pharyngitis or in sinusitis. So in sinusitis, again, if it is localized only to one side, then it is most probably a bacterial involvement. So yes, if it is mucopurulent, if it is unilateral, if there is, and this is not only one feature, along there has to be at least three features for us to say that this is a bacterial involvement. First is that it has to be a unilateral, it has to be unilateral, mucopurulent secretions. The fever has to be high. If there is only high fever, if the fever is only high, are you listening to me? Last time also we did that when the fever is high, somebody told me that when the fever is high, it is always bacterial. So it is not that in viral you cannot have high fever. Here we are seeing that there has to be three features together. If there is low fever, but along with that there are other three features, we say that it is bacterial. Okay, so if there is high fever, only high fever will not say that it is bacterial. Along with that, there has to be mucopurulent secretion, it has to be a unilateral involvement, there has to be severe pain, tenderness over the maxillary sinus area, severe local pain, or another very important history. Just see here what is given here, that the woman had 2 week history of nasal congestion. She initially felt better and then she took some medication, and now again the symptoms have returned. So do you think that any viral condition will have such a long history? No, viral condition is usually it is less than 10 days. So if anything is more than 10 days, we think this is bacterial. Or not only more than 10 days, we can also say that the patient was improving, but suddenly again the patient has started deteriorating. That is what is known as double sickening. So what is the meaning of double sickening? Why was the patient benefiting initially? Because maybe initially it was viral, and then because the immunity went down, because of viral congestion, because of viral edema, the osteomeatal complex got blocked, the opening of the maxillary sinus got blocked, that led to negative pressure and obstruction of drainage, and now there is bacterial superimposition, super infection. So then now the patient's condition has worsened. So this is again a very important feature. This is the fourth feature. Okay, so if these things are present, and these things are something that you will need whichever doctor you become, these are the things which each and everybody will ask you in your house, in your family, and definitely in ENT you will have to know this, yes, for your exams. So what are the symptoms that will tell you whether it is bacterial? Any three of the following three have to be present: mucopurulent discharge, unilateral, severe facial pain, which is usually unilateral, high fever, and double sickening, deterioration after the initial. So initially maybe it was viral, but now again deterioration means now there is bacterial super infection. So most of these features are present here in this patient, which means that this is a bacterial presentation. So now tell me, how will you manage this patient? Now what will be the management of this patient be? Will we give amoxicillin and clavulanic acid? Yes. Yes, you will give the antibiotic because this is a bacterial presentation. So now the next thing that you ask me, and all these things your examiner is going to ask you, or this is asked as MCQs, that what you're giving antibiotic against which organism, which means that if the sinusitis is bacterial, what is the most common bacterial cause of sinusitis? Yes. So yes, it is. Yes, tell me, I'm waiting for your answer. Yes, it is Streptococcus pneumoniae. Streptococcus pneumoniae, pneumococcus. So, which means that, will you give amoxiclav? Yes. Now, if I ask you, somebody asked me that, ma'am, should I take ciproflox? Should I take ciproflox for my sinusitis? Now, tell me, should that person take ciproflox for sinusitis? Yes or no? So, ciproflox, does it have a gram positive or a gram negative cover? It has got a gram negative cover, so that will not work here. Yes, you will go for amoxiclav. You can go for cefuroxime. So, but not ciproflox. Yes, so will you give supportive management with analgesics, decongestants, nasal irrigation? Yes. What is nasal irrigation? Nasal irrigation is with saline. That decreases all the crust, that removes all the crust, so it helps in proper ventilation of the sinuses. Now, this is another important thing. Will you go for a X-ray or a CT? Yes or no? Will you go for a X-ray or a CT? A very straight question. In acute sinusitis, will you go for a X-ray or a CT? Is the diagnosis of acute sinusitis made radiologically, or is it a clinical diagnosis? Divya, yes, no. Yes, Divya says no, we will not go. Yes, so we do not do any radiological investigation for the diagnosis of sinusitis, which is acute. Acute sinusitis is clinical diagnosis, and all that was given in the history and the examination tells you that this is acute infection. And in acute infection, do you go for FES? Do you go for surgery? The primary management is medical management. Yes, tell me, will you go for surgery? Now, let me not ask you, will you go for surgery? Let me ask you this question and let me stimulate your mind to think this. This is acute presentation and I am going to do surgery of this patient. So tell me, in which acute presentation will we go for surgery? In which patient of acute sinusitis, the management along with the medical management will be surgical management also? Yes, tell me. Uh, yes, Prachi, tell me. Yes, Prachi, Tanmay, Amruta, Eva, Swati. Tell me, all of you, tell me. Yes, I am telling you that I want to go for surgery in this patient, and this was the patient of acute sinusitis. So, what is this patient having? In which acute sinusitis? Divya says only in chronic we go for surgery. Yes, but I am not asking you, I am telling you, yes, acute management is medical management. In which cases of acute sinusitis will we go for surgical management? Yes, tell me. Recurrent complications. Yes, I saw that answer. Yes, very good. Complication. Yes, see what all name you keep, melody cover. Okay, so yes, if there is complication, so if there is a surgical management of acute rhinosinusitis is done only in complication, only when acute sinusitis has complication. And now comes the next question for you. What is the most common complication of acute sinusitis? Most common complication of acute sinusitis is most common complication of acute sinusitis. So sinusitis complications are divided into three. Yes, orbital, or it can be intracranial, or it is bony. In bony, it is osteomyelitis. So out of these, which is the most common acute complication, most common complication of acute sinusitis? Yes, very good. This is orbital complication. So if there is orbital abscess, if there is intracranial abscess, then any abscess needs to be drained. So we will drain the abscess. Or if in any complication, so we are not talking about no significant improvement in acute sinusitis, no significant improvement in the complication. Suppose you are treating a patient of orbital abscess. or you're treating a patient of any intracranial abscess, okay, you have given the patient antibiotics, IV antibiotics you have given for at least 24 hours, and the patient's condition is deteriorating, patient is not benefiting, then we know that no, we immediately have to go for the surgical management. And here in the surgical management of acute rhinosinusitis, again we will go for PES, we will drain the abscess. Now this year in AIMS there was one word that was used, and that was trephination. Trephination, that was one of the choice, that was not the answer of that question, but one of the choice that was given was trephination of the a picture was given and was asked that what is that picture, and one of the choices was trephination. That was not the answer, but what exactly is trephination? Yes, so what is trephination of frontal sinus? Now, whenever there is any abscess of the frontal sinus which is not benefiting by medical management, now we know that this is the frontal sinus here. Frontal sinus entirely, if there is abscess in the frontal sinus and it ruptures entirely, it will lead to subperiosteal abscess. Can you tell me the name of the subperiosteal abscess? What is that subperiosteal abscess known as? Yes, very good. That is known as Pott's Puffy tumor. Pott's Puffy tumor. Or if it ruptures internally, it will lead to brain abscess. So again, this is another question that is asked: brain abscess, intracranial complication. If it occurs most commonly following which sinusitis? Yes, it occurs most commonly. The brain abscess occurs. The most common brain abscess is frontal lobe abscess, and it occurs most commonly following which sinusitis? Yes, the frontal sinusitis. So if there is any abscess here which is associated either with brain abscess, or it is present very laterally in the frontal sinus, which we know that it will be very difficult to approach endoscopically. So then what we do is we make an opening. Just see where we are making the opening. We make an opening on the inner side, 1 to 1.5 centimeters opening on the inner side of the brow, of the eyebrow. We give the incision, we raise the periosteum as you are seeing here in this picture. We are raising the periosteum, we make a hole in the floor and the interior wall of the frontal sinus, we drain it, and as we are seeing in the third picture, we put a drain so that we can wash put a wash into the put saline and wash the sinus, and for permanent drainage post operatively. This drain is usually removed after 7 days once the patient situation improves. So this is what is trephination of the sinus, of the frontal sinus. So that is how you are going to deal with the acute frontal sinusitis. Acute frontal sinusitis. So just quickly, I'm just going to give a summary to you. Whenever there is a patient of sinusitis, the first thing we need to see is whether it is acute or chronic. And then we need to see that, okay, we have diagnosed this as sinusitis, we know it is acute sinusitis. Now we come to the management. So for that we will have to know whether it is bacterial or whether it is viral. So there are certain features which will tell you it is bacterial, certain features which will tell you viral. Accordingly you will give the management. And yes, so acute sinusitis, the management, the diagnosis is clinical, the management is, in most of the cases, it is a medical management. Surgical management is given only if there is complication which is not benefiting by medical management. So now the second question we have here is, a 32-year-old man has a 5-day history of persistent nasal congestion, pain in the right forehead area with clear nasal discharge. Okay, so there is clear nasal discharge, there is mild cough. The patient reports he has similar episodes in the past which were helped by antibiotics. Okay, medical history is otherwise unremarkable. He is currently on no medication. On physical examination, vital signs including temperature are normal, which means right now he is not having any fever. Mild right supraorbital ridge tenderness is present. So there is tenderness over the supraorbital ridge. Okay, the nares are patent, clear mucoid discharge, there is no pharyngeal erythema or exudate, the lungs are clear to auscultation. So now you tell me whether this is, what is the diagnosis? What is the diagnosis of this patient? This patient has come with 5-day history. 5 दिन से नाक बंद है उसका, and there is nasal discharge. Yes, नाक से बलगम आ रही है, नाक बंद है, नाक से बलगम आ रही है. The next thing you ask, नाक से बलगम कैसी आ रही है? पीले रंग की है, yellowish है, white है. What is telling you? It is white in color. It is white in color. Yes, so what is this? This is, yes, very good. Yes, this is a viral presentation. This is viral presentation. None of the features of bacterial are there. Mucopurulent discharge is not there. Yes, severe high fever is not there. There is no. So whenever you are seeing the presentation again, you revise what are the features which will tell you it is bacterial. So this is viral. So what will be the best initial management? What will be the best initial management? Will you go for antibiotic? Yes or no? Will you go for CT? Will you go for X-ray? Will you go for symptomatic management? A, B, C, D. What's the management here? Yes, yes, quickly. Yes, very good. Yes, Nusrat says it is D. Yes, so this is not bacterial, so we are not going to go for antibiotic. CT and X-rays not required in acute sinusitis. This is acute. So 5-day, no. Symptomatic treatment? Yes, that is what is will be the management here. Okay, so quickly coming to the, so now you know what the difference is and how you need to differentiate. Next time, any patient, you can treat the patient yourself. Yes. Okay, so now we come to the next question. The next question here is a 37-year-old man is evaluated for frontal headache. So he has frontal headaches, nasal obstruction, mucopurulent nasal discharge. So he has nasal obstruction, nasal discharge, frontal headache that have persistent intermittently for several years. Okay, so for several years he's been having this. Now he has fatigue, cough, decreased sense of smell, hyposmia. Over the past 4 months, he has received 3 successive courses of antibiotic for worsening symptoms. Most recently, he completed a 3-week course of amoxiclav in combination with nasal steroid. So he has taken amoxiclav, he has taken nasal steroid, he has taken nasal saline irrigation and oral decongestant. This treatment regimen provided only partial relief. He has no history of allergic rhinitis, eczema, drug allergy. On physical examination, he is afebrile. Percussion of his right maxillary sinus elicits mild tenderness. Okay, so these are, yes, this is what is the most appropriate next step of management. So what is in your mind? What is the diagnosis that you have made of this patient who has been troubled? He is being troubled. Yes, he's troubled because of the because of the headache. He's been having all this for the past 4 months. For the past 4 months, he's been having this. Okay, so he has received successive courses of antibiotic already. And yes, now I can see Vaishnavi, and yes, some of you are asking me that Tanmay, Vaishnavi, I think they are asking me about the previous question. What they are asking me about this patient is, are we not giving antibiotic? Why don't we give antibiotic to prevent super infection? Now, just see this antibiotic, the super infections do not occur always. It is not necessary that this patient will develop a super infection. So we will not give unnecessary antibiotic that will lead to resistance, development of resistance if it is not needed. It is not needed right now. The patient is, yes, just remember this, right now when the patient is not having any bacterial infection, if we are giving antibiotic, what is antibiotic doing? Is there any bacteria that it is going to kill? No, it is not. And what if you stop the antibiotic after 5 days and after 5 days the super infection occurs? So you cannot prevent the super infection. You cannot prevent super infection by giving antibiotic right now. So you are just managing the viral, and if the patient does not benefit by the symptomatic treatment, you can any day start antibiotic. What do you think? Yes, Vaishnavi? Yes, Tanmay, what do you think? You cannot give us, we can always give start antibiotics later on also. Okay, so now, yes, I hope you have come to this. You have already thought about this question that this patient is been having, he's been troubled for 4 months. Yes, yes, so yes, I can see all of you answering that this is chronic sinusitis. Yes, excellent, this is chronic sinusitis. Now tell me, what will you go for next? Will you go for diagnostic endoscopy? Will you go for CT? Yes, this is a chronic presentation. So now we need to, he has already taken 3 successive courses of antibiotics. We will go for endoscopy. Yes. So yes, endoscopy was done. And on endoscopy, the turbinates were congested with edema and mucopus in the middle meatus. So middle meatus was infected. The septum was deviated to right, so there was a DNS also. There was no polyps. So what will be the most appropriate next step of management? Yes, so first will be endoscopy. First is endoscopy. Next, now you have seen on endoscopy that the middle meatus is inflamed. The middle meatus has pus. It is edema. So now you want to see the inside of the sinuses also. By endoscopy, you can only see up till the meatus. You cannot go into the sinuses and see which all sinuses are involved. And we have made the diagnosis that this is a patient of chronic sinusitis. So what is there in this patient? Is there some anatomical abnormality? Is there some concabulosa? Yes, can you tell me what is concabulosa? Yes, very good. Pneumatized turbinate. Or is there any Haller cell? What is Haller cell? Yes, intraorbital cell blocking the drainage of maxillary sinus. So what is the problem that this patient is not benefiting? He has taken every possible treatment that he could take for chronic sinusitis. He has taken antibiotic, he has taken steroid spray, he has taken decongestant, saline irrigation. Why is this patient not benefiting? So we are now going to go for a CT. Yes, with CT, very good. We will go for NCCT. So we got the NCCT done, and yes, the NCCT showed that there is pansinusitis. All the sinuses are inflamed, are infected, are filled with secretions. What will be your next step of management? How are you going to manage this patient? Will you go for medical management or will you go for surgical management in this patient? Will you go for medical management or surgical management? Yes, we know that this, what is chronic sinusitis? Chronic means it is more than 12 weeks. Yes. So in chronic sinusitis, always, the primary management is medical management. We give medical management for at least 1 month. 1 month duration medical management is given. If no benefit, only then we go for FES. No benefit, we go for FES. And what we are seeing here, that this patient has been troubled for 4 months and he already had 3 successive courses of antibiotic, and last was 3-week course, which means that he has already been given the maximum medical management that we give in chronic sinusitis, and that too he has taken every possible thing. It is not that he has taken only antibiotic, he has taken steroids. Yes, why are steroids given in the nose? In chronic sinusitis, yes, to decrease the inflammation, decrease the edema, to increase the patency of the sinuses, increase the ventilation of the sinuses. So every possible management, this exactly is the management of chronic sinusitis. So every possible he has taken for 3 weeks. So now we are going to go for surgery. Yes, with surgery, we are going to go for FES, functional endoscopic sinus surgery. So that is how you diagnose a chronic sinusitis more than 3 weeks. So to summarize quickly in a minute, yes, chronic, when we say chronic when it is more than 3 weeks, more than 3 months. And how is it important? Because in chronic sinusitis, we know that there is some abnormality because of which the patient is not benefiting. We give medical management. If the patient benefits by medical management, excellent. But if the patient is not benefiting by medical management of 1 month duration, then we are going to operate. We are going to go for FES. Yes. Okay, so now we have the next question here. 60-year-old man gives the history of bilateral nasal obstruction. Okay, so he is elderly here, so we are noting the age. 60-year-old man, bilateral nasal obstruction, bilateral, yes, so these are the important things. Nasal obstruction, watery nasal discharge. So he has nasal obstruction, nasal discharge, but please note what it is watery. It's been there for few months. Okay, he has now come to the OPD since the blockage seemed worse and the discharge has changed to yellow. So previously it was watery discharge, now it has changed to yellow. He is feeling unwell with fever, headache, facial pain and tenderness. And on anterior rhinoscopy, you are seeing pulmonary nasal discharge. So what is the diagnosis? Yes, so what is being asked is the management. But for that, you need to know what the diagnosis is. What do you think? What will be the line of management? What do you think? Yes? What do you think is the line of management that you're going to do here? 60-year-old man has bilateral nasal obstruction. Right now he has, so what do you think this is? Yes, okay. Swati is asking me, why do we do endoscopy first? Why not we go for NCCT directly? Yes, because see, when we do endoscopy, I think you're asking me for the previous question, that when we do endoscopy, we come to know whether there is any abnormal looking mucosa, whether there is whether this is a patient who can be a patient of chronic obstruction because of some tumor, because of some mass, or we can exactly know that what if there is a DNS, like we came to know in this patient that there is a DNS. So if we go for endoscopy, that gives us additional finding. Maybe we are thinking that all this presentation has occurred because of some growth that is occurring there. So endoscopy gives up some additional findings, which probably the CT, on CT, the exact appearance of the mucosa, the exact appearance of if there is any mass, all that will, you will know where all it is. But exact appearance, or only if there is bony erosion, you'll be able to see that in CT. But endoscopy also tells you a lot about the things that are present. So endoscopy is always first, and endoscopy is just, it is so simple to do. You're not exposing the patient to radiation. So CT, you many times what we do is, when we do endoscopy, we come to know that there is uh, chronic things. So if the patient is just of 3 months, then we can just give antibiotic and see, and if the patient is not benefiting, then we can go for NCCT. Now in this patient, the patient has already taken everything. The patient has taken course of antibiotic also after 3 months. He is now more than 4 months he's been troubled. So now we would like to see that why this patient has not benefited by the medical management. What is there in this patient which we are not able to find by endoscopy, that will tell us, is there any concabulosa, is there any Haller cell, or any other anatomical abnormality. So that we can know by CT. Is that clear now? Yes? Okay, so now, yes. So here in this patient, what do you think is this patient having? This patient, excellent. Yes, I can see all of you are telling me the correct answer. Nikesh, Shubham, Tanmay, all of you are telling me that this is a superimposed bacterial sinusitis. Okay, so there is superimposed bacterial sinusitis. So what should we do? What should we do? This patient has infection right now, and on anterior endoscopy, all I am seeing is purulent nasal discharge. What do we do? Okay, we will give antibiotics. So I gave the patient antibiotics, okay, because that is all I am able to see anyway. In infective, we have to give antibiotics. So I gave him antibiotic. So he was prescribed antibiotic to treat the sinusitis. The patient was asked to return to the examination once the course of antibiotic was over. And now examination showed bilateral yellowish gray grape-like nasal polyps with the help of nasal speculum. Means just I have done anterior endoscopy. Right now all the yellowish secretion is gone and I can see grape like nasal polyps. Okay, so now tell me that what is this patient, why is this, right now he's having superimposed, but what was it superimposed on? I'm sure I can see someone is telling me that that there was a viral infection following which there is bacterial infection. But do you think a viral infection will last for few months? No, viral infection will not last for few months. So right now he is having a super infection of bacteria for which we have given antibiotics. So this was superimposed on what? On polyp. Okay, now tell me what is the deal. Tell me, yes, quickly, I can see. Yes, I am seeing the answer is ethmoidal polyp. Okay, it is ethmoidal polyp. Tell me the cause. What is the cause, do you think this patient might be having? He is having bilateral obstruction, bilateral polyps. Bilateral polyps we know are ethmoidal. Ethmoidal bilateral means, yes, I have told you very, very clearly when we learnt in our nasal polyps video that whenever it is bilateral, whenever the polyps that we are seeing are bilateral, it means that there is a systemic condition which is involving both. Yes. So what is the most common systemic condition that involves both the sinuses? I can also see that you are saying malignancy. Wonderful. So these are the DD that will come to your mind, and these are the DD that are asked in your exam. What will be the differential diagnosis? Yes, it can be malignancy, but what do you think in this patient? Is it pointing very much towards malignancy? Think and tell me. Is it? Yes, it is. The patient is elderly. Very good. That is one point that is telling you malignancy. What are the things that is telling you against malignancy? What is telling you that this is not malignancy? Yes? Yes, very good. Bilateral. Bilateral involvement tells us that this is probably not malignancy. If it is malignancy, why will it be bilateral? Yes, watery nasal discharge. Usually in malignancy, there is blood thin nasal discharge. But anyway, we can give malignancy. Yes, so this as a DD. Okay. Okay, so it's model polyp. Very good. I can see that you are telling me that it is allergy. Yes, it can be allergy. That is the first and the foremost thing that will come to your mind. It can be, yes, you can rule out malignancy. You can rule out, yes. Can it be? Tell me anything more. Tell me anything more that can be the differential diagnosis. Can be allergic fungal sinusitis. Yes or no? Can it be allergic fungal sinusitis? Fungal sinusitis is different from the allergic bilateral ethmoidal polyp. Now, tell me, can it be allergic fungal sinusitis? Yes, if you have read your topic well, can it be allergic fungal sinusitis? Yes or no? Yes, I can see Chuck Strauss. Chuck Strauss, yes, can present at this age. It can present a little earlier also. Bilateral nasal obstruction. There, the patient will have asthma also. Yes, all that is not mentioned here, but anyway, we can take the history of asthma. We can take the history of lung involvement. Very good. So, all of you who do not know what is Chuck Strauss, you're going to read what is Chuck Strauss. Now, I can see Samter's. Okay, Samter's triad. Quickly tell me what is Samter's triad. Yes, that is nasal polyposis along with asthma and along with, what is the third point? First is nasal polyps, second is asthma, and the third is aspirin sensitivity. Aspirin sensitivity leads to aggravates both this condition, asthma and nasal polyps. Then we call it as Samter's triad. Now I can also see you writing cystic fibrosis. Now just tell me, cystic fibrosis, will this be the age? Cystic fibrosis is a congenital condition. It will not be in this. Yes, Divya says that it cannot be fungal sinusitis. Yes, what are the points again? Fungal sinusitis. Excellent. Yes, mucinous discharge. This will be mucinous discharge. Here it is watery nasal discharge. Very, very important. Allergic fungal sinusitis is usually unilateral. Wonderful. I can see that all of you, whatever you have read, you are applying it clinically. Yes, it is not just for answering your questions, it is for seeing patients because you're doctors. Yes. So mucinous discharge, unilateral presentation, all that is not here. So it is probably not allergic fungal sinusitis. Anyway, we can keep that in a differential diagnosis. Okay. So what will be a line of management? How are you going to manage this patient? We have seen that this patient has polyp, and most probably we have come to a conclusion that this is a allergic polyp, bilateral allergic ethmoidal polyp. So how will you manage this patient? How will you manage this patient? Yes, will you go for any medical management, or will you directly go for functional endoscopic sinus surgery? Yes, very good. We are going to go first for medical management. We will go for medical management with anti-allergics. We will give nasal steroid sprays, and if the patient benefits by that, very good. Because this is a recurrent condition, allergic polyps are recurrent. So if the patient is managed by medical management, that is excellent. If the patient does not get managed by medical management, then we go for FES. Only then we go for FES. Okay, so now what we saw in this is that whenever it is a polyp, so quickly to summarize, whenever there is polyps that we are seeing, we need to see the age of the patient, we need to see whether it is unilateral or bilateral, and if the age is a child, our DD will change. In a child, we are not going to think of malignancy. In a 60-year age, we are not going to think of cystic fibrosis. We are not going to think of ciliary dysfunction like Catagna syndrome in 60 years. In 60 years, we are going to think of more common things like malignancy. We are going to think of allergy. And then we need to see whether it is unilateral or bilateral. If it is bilateral, we know it is a systemic condition involving both the sides. So if it is elderly with bilateral, then the most likely diagnosis goes to allergic polyps. Yes, if it was unilateral and elderly, our first DD would be malignancy. And then we could have also thought of allergic fungal sinusitis, where we would have seen mucinous lateral nasal obstruction and watery nasal discharge since few months. Okay, so now the age has changed to 10 years. Okay, so when the age changes, the things that we are going to think of changes. So there is bilateral here. Yes, so I'm sure that All the things already must have started coming to your mind. It is a 10-year child, bilateral nasal obstruction, watery nasal discharge. He has been brought to the OPD since the blockage, so it's seeming very similar like previous, yes? Blockage has become worse now, discharge has changed to yellow, he's feeling unwell, fever, headache, facial pain and tenderness. He was prescribed broad spectrum antibiotic because this is a acute bacterial superinfection on something which was already present. So broad spectrum antibiotic was given to treat sinusitis. Patient was asked to return for examination once the course of antibiotic was over, and now the examination showed bilateral yellowish gray grape-like polyps visible with the help of nasal speculum. So now what are the things that are coming to your mind? Yes. Yes, tell me now what comes to your mind. Now the age has changed. So will you keep malignancy? No. Now if it is bilateral, it is a child, what are the things that come to your mind? Bilateral and it is child. Bilateral means it is a systemic condition because of which it is involving both the sides. So what will come to your mind? Yes, the first thing, think of the more common things first. More common will be first is allergy. Yes, allergy. Allergic is usually seen in young, is usually seen in middle age. But as compared to cystic fibrosis, as compared to primary ciliary dyskinesia, this allergy is still more common. So yes, we will think of allergy. Very good. We will think of cystic fibrosis. And I'm sure you've not just read this much about cystic fibrosis. Yes, let me just bombard you about questions of cystic fibrosis and let me see whether you're able to answer or not. Cystic fibrosis. What is the cause of cystic fibrosis? What is the cause of cystic fibrosis? Yes, is it, what is the cause of cystic fibrosis? How do you diagnose cystic fibrosis? What is the treatment of cystic fibrosis? Yes, cystic fibrosis. So have you read about all these things? If you have read about all these things, very good. If you have not read, you need to, any word that you are speaking or you are hearing, go back and see what it is. That is the way of learning things. What is the cause of cystic fibrosis? I am not getting any answers. What is the cause of cystic fibrosis? What is the cause? Yes, it is known as mucoviscosis. What is that? Yes, this is a genetic condition, chloride channel defect. Very good, genetic defect. Autosomal recessive or autosomal dominant? This is inherited as autosomal recessive. How do you diagnose it? Yes, by sweat chloride test. How do you treat this patient? The treatment of this patient is just symptomatic. This is a genetic disorder. You cannot change the genes. You cannot alter the genes. So all you can do is you can symptomatically manage the patient. So if the patient is having bilateral multiple polyps obstructing both the nostril and cystic fibrosis, then we go for FES. It can be primary ciliary dyskinesia. Primary ciliary dyskinesia. For example, yes, which syndrome? Which syndrome? Yes, Catagna syndrome. Catagna syndrome. Yes, so if I bombard you on question about Catagna syndrome, what is Catagna syndrome? What is Catagna syndrome? Is it an infective condition? Is it a genetic condition? Is it acquired condition? What is the presenting feature of Catagna syndrome? What is the triad of Catagna syndrome? How do you manage a patient of Catagna syndrome? Yes, Catagnas, is it autosomal dominant or recessive? Again, this is a recessive. It is a recessive condition. No, it is not dominant. What are the three features of Catagna syndrome? So when you know of any word, you should know what this is. Yes, so Catagna syndrome is chronic sinusitis. It is bronchiectasis, and along with there is situs inversus. So these patients very commonly come to ENT OPD with these complaints, and there will be bilateral involvement. So all these are the things that will come to our mind when we see bilateral involvement. So how are you going to manage this patient? According to what you diagnose. So if it is allergic thing, then we are going to give medical management, and then we go for surgical management, that is specific. Okay, now when in polyps. Now listen to this question very carefully. In which polyps do we directly go for surgical management? When in polyps do we directly go for FES? We do not want to give any medical management. In which polyps do we not give medical management? We directly go for surgical management. Yes? Yes? Yes, when there is fungal sinusitis, This is a repeated question of your exam, repeated question of aims, repeated question of NEET, repeated question of chipmer, repeated question of PGI, that in which do not go for medical management. The primary management is surgical in allergic fungal sinusitis. We know allergic fungal sinusitis is because of a fungus. While we are breathing, the fungus has got entrapped in the sinus, and that fungus, because the patient is allergic to that fungus, the patient is responding very severely, producing eosinophils, thick mucinous secretions, obstructing the sinuses, leading to polyp formation. So here the medical management of antifungal will not help. We need to just remove. It is like the fungus behaving like a foreign body to which the patient is allergic to. So remove it. Yes, so in allergic fungal, in anatomical abnormalities, if there is any concabulosa, if there is any Haller cell, if there is any DNS leading to obstruction, will it benefit by medical management? No. So then the primary management is surgical management. That is why doing CT is so important. In cystic fibrosis, we know that the obstruction, or in Catagna syndrome, we know that the patient is having severe obstruction, and medical management is not going to help. Medical management with antibiotic will just relieve temporarily the superinfection, the bacterial superinfection, but not the primary cause. So we need to ventilate the sinuses, give the patient good breathing, and that will not happen by medical management. In these cases, we have to go for surgical management. Again, in antroconal polyp, we go for surgical management. This is a bacterial infection, localized obstruction of the maxillary sinuses. So in these cases, we go for primary surgical management. So that was just quickly to summarize that whenever there is any polyp that we are seeing, we need to come to the cause. And what are the things that will help you to come to the cause? First thing, whether it is unilateral or bilateral, and second thing, whether it is a child or whether it is an adult. Because if it is a child, then you know that these are the DD. If it is adult, these are the DD. You can prevent exposing the patient to all those tests which are unnecessary for that patient. Yes. So accordingly will be your steps for investigation. Accordingly will be your history. Yes. If there is any child, you will ask for if you're thinking of cystic fibrosis, you will ask for intestinal problems, you will ask for pancreatic, for pain, for pancreatic enzymes, you will get the test done. You will ask for lung involvement, you will ask for certain things which are specific for that condition. So like that will be your history. So that is how you are going to proceed. So that was something very simple, that was something very common. But yes, that is something that the moment you see the patient, you should know that yes, this is the diagnosis, this is viral, bacterial, this is polyp, this is how I'm going to manage this patient. So that was what we have done today. And I do all your MCQs from these respective chapters from the book ENT for entrance exams. There has not been a question till date that has been asked for the past 4 5 years which was not there in the book. So read it. And yes, the message for today that I want to give you and that you need to take home is that baby steps count. As long as you're going forward, you add them all up, and one day you look back and you'll be surprised at where you might get to. So small little things, as I gave you in the beginning the example of such like ophthalmic artery. I told you ophthalmic artery. Now if I say ophthalmic vein, I say ophthalmic nerve. Does it immediately come to your mind? So each and every time when you read something which you're not very sure about, yes, I know this is, but what exactly does not come, the picture does not come to your mind, go back, see again. Maybe next time you will have to see again, maybe once more you will have to see again. But after that, the moment you see the any person, you exactly can mark that area where that exactly that artery, that vein, that nerve is going, or what exactly that condition is. And when you give your exams later on, where you feel that all this is so natural, all this is so simple. And to us, when you hear the interviews and when you hear great people, what it feels like that they have achieved success overnight. But believe me, no success is achieved overnight. If you just look closely, you know that it was actually the small, small baby steps which led to the success. No success is overnight. So next class we are going to have, all of you have requested, and what we are going to have next time is the X-ray of the nose. X-ray is relevant in the nose, the CT, the radiological tests that are relevant in the nose, the endoscopy of the nose, and if time permits, we will also do FES. So the radiological investigation, X-ray, CT, and the FES if time permits. So we will see how it is important. And when we did, nobody told me that we are going to get for polyps or for sinusitis. Nobody told me that we are going to get X-ray done. You always told me that we will do endoscopy and then we will directly go to CT. So do we get X-ray done? Do we get X-ray done? Let us see that next week. Yes. So happy learning and enjoy studying. Enjoy not only studying, enjoy, do each and everything that you want to do it today, do it now, as if it was the last day that we are living. Live each day fully. So God bless you and love you all.